mute everyone, Stephanie, apart from myself for the moment, just so we don't get any background. Plan is to have a slightly shorter webinar today because the agenda's not too packed, thankfully. Any questions, please put them in the chat bar or raise your hand and we'll come round to you. And Karen, if you can maybe help me with the chat bar, as Alpina's not here today. Is that all right? So we'll start off with Karen, yourself, who's going to go through the new branding for NHC.
Yeah, it's probably a little different, and I'm sure colleagues, you can sort of switch off and slowly get into this as you wish, but we just wanted to share with you a couple of things that are happening in terms of NHC's development around becoming a community interest company. If you move on, Steph, to the next slide, colleagues will remember that we have secured the agreement of yourselves and the system, and we've now gone through the various regulatory processes to formalise that we are a CIC. We're going to have a little bit of a celebration and a launch on the 22nd of February. And I guess it's just an opportunity to underscore what does that mean. It means that all the assets, so anything that sits within the NHC by way of money or people or resource, are now locked in for the value of primary care and the residents in Newham. So no matter what happens, that's now a sort of given forevermore. But it also means, and I think it's a positive conversation with commissioners, because we know that community interest companies are more successful in securing contracts, and certainly in the public sector, people see the value of that way of operating. If we just move on briefly, Steph, but colleagues will recall that part of the decision making, it also secured the same way in which we're working. So the leadership, the ownership, and the direction of the organisation is still very much set by yourselves and our GP members. So some of the things don't change, but I think what's really important is that locked in commitment for the future. So as part of that process, we thought we would slightly refresh our branding and bring a new look to the way in which we're working. And we're using the new branding today just to show you, but we'll sort of formally go live, if you like, with it all from the 22nd of February. So if we just move on, the logo that we're now going to be used going forward is this one. And you'll see it clearly states that we are a community interest company, and we've used 4 different colours to represent the different parts of our organisation and our connections. So the blue is the sort of corporate reflection of NHC. The green is the NHS colour for patients, so we've incorporated that to represent our voice and our conversation with patients. The turquoise blue is a representation for members and how our conversation is across the borough with our membership, and then the pink is to reflect our partnership with the wider system, local authority, and various organisations. I'm getting feedback, Steph, I don't know why. So you'll just see we've created, if we just flick through, Steph, we've created a suite of marketing materials to be able to sort of make sure that these visuals are right the way through the way in which we're now communicating ourselves across the borough. And in our social media, we will also represent the new branding and the new sort of identity for NHC as a community interest company. And hopefully you will start to see our visual identity as we communicate in it. And then just finally, because it's really just a quick refresh for you, just to let you know that as part of that process, we are recasting and completely redesigning our website. Probably if you've been on our website, you'll have seen it's quite out of date, but rather than tweak it and just amend it, this was an opportunity to completely revamp. And so our comms team are recasting the whole thing, and it will be part of our launch from the 22nd of February, that the identity in terms of our website and our social media assets will all reflect that new visual. So hopefully that's something you'll see as you're going forward in terms of your interactions with us, and just a little bit of an explanation as to why we've done it. That's it. Thank you, Nadine.
Thanks, Karen. Yeah, and just some comments just mentioning about the CIC. So yeah, looks really good. Thank you, Karen. Can't see any questions, so we'll move on. So is that a hand up or just no? Okay. So long COVID service. We're just going to get an update from Dr Chetna Patel, who works a local GP who works in the service, and also Andrew Cook, who's one of the managers from Elft, who run the service. Hi Chetna and Andrew. Shall I hand over to you to just give us an update on the long COVID service?
Brilliant. Yeah. Hi there. Thank you. Yeah. So thanks for having us on your agenda. I'm Andrew Cook, and I'm the clinical lead for the service. I'm joined by Dr. Chetna Patel, who I'll let introduce herself when we come onto her slides in a couple of seconds. So if I could just get the next slide, Steph. The reason we wanted to be here primarily was to tell you that we are still here as a service. We're still wanting referrals. We've just recently had confirmation that we are being funded for another financial year. So we're definitely going to be here for at least kind of 12 to 14 months further. And we're just going to kind of quickly whiz through a couple of slides just to talk you through the types of patients that we want and the types of work that we do with those patients. So we are a therapy-led service. I think that's really important to mention. So I'm an occupational therapist by background. We do have medical input into our team, which Dr. Chetna will touch on in a minute, but our work with patients is in a kind of therapeutic capacity, and that's primarily occupational therapy, physio. We've got a psychotherapist starting with us soon. And we have been around for 2 years now. We started in January 2021. Those who haven't heard from our service for a period of time, we originally set up as purely a triage service. So referrals would come to us, they would be triaged, and then our support would be by way of kind of onward referral to other services. That changed in November of 2021, so kind of a year and a half ago. We now are a kind of fully established service to take on those referrals, triage them, and then provide some therapeutic intervention, which I am going to touch upon in a few slides' time. So, Chetna, can I hand over to you?
Yeah, thanks, Andrew. Hi, everyone. So I'm Dr. Chetna Patel. I'm a GP. I've been working in the long COVID service, and I also have postgraduate qualifications in lifestyle medicine. So we're just going to do a few slides just as an overview of long COVID. So it's estimated that 2 million people in the UK are self-reported to be experiencing symptoms of long COVID, and that was in July of 22. So NICE uses the following definitions and clinical case definitions to identify and diagnose long COVID. So acute COVID-19 are the signs and symptoms of COVID-19 that occur for up to 4 weeks. And the majority of people that do experience acute COVID-19 will recover within this time, so within a few days or a few weeks. Some patients have ongoing symptoms, and that is classed as ongoing COVID-19. And for some patients, they will have symptoms for longer than this, for longer than 12 weeks. And this is post-COVID-19 syndrome or long COVID. So the NICE definition for the diagnosis is the signs and symptoms that develop during or after an infection, which is consistent with COVID-19. The symptoms continue for 12 weeks or longer. They're not explained by an alternative diagnosis, and it usually presents with clusters of symptoms. They can overlap, they can fluctuate, they can change over time, and as I'm sure you've realised, they can affect any system of the body. Now, it's not possible to predict whether a person is going to develop long COVID based on the severity of their acute illness, or the symptoms or the cluster of symptoms, or whether they were admitted to hospital. Next slide, please. So there's a large range of symptoms that are associated with long COVID, and some studies suggest that there's over 200 associated symptoms. Now, symptoms after acute COVID-19 can be highly variable and also wide-ranging. Now, the most common symptoms which have been self-reported are fatigue, which is up to 62%, shortness of breath, 37%, and also loss of smell, muscle aches and body pains, and also difficulty concentrating. And some of the other symptoms are also shown in the box. Next slide, please. So this is a slide showing a list of symptoms in a patient that was reviewed in the long COVID service. And the list just really highlights the complexity of the symptoms experienced by patients. Next slide, please. And as you can see, they may have symptoms that cover a number of systems in the body, and a patient like this may end up having reviews with different specialities as we learn more about long COVID. Next slide, please. So there's lots of information on the NICE guideline for long COVID, which covers diagnosis, investigations and assessment. Now, as an overview for our service, please do consider doing an FBC, U&Es and LFTs as a minimum. Also, a physical examination is usually indicated depending on the symptoms that the patient has, and other investigations which may be indicated are a chest X-ray or an ECG. Now, NICE suggests offering tests and investigations which are tailored to that person's signs and symptoms. The idea is to rule out anything that's acute or life-threatening, to find out if the symptoms are being caused by COVID-19 or long COVID, or is this something completely new or an unrelated diagnosis? Next slide, please.
Thank you, Chetna.
And
I'll
I'll
take
hand
back
you over to
over.
Andrew.
Thank you. So just to kind of discuss referring to our service. So once the other causes of symptoms have been ruled out, any other organic causes, and the patient's symptoms have persisted for 12 weeks or longer, we then welcome a referral. Our email address for the service is on the slide there, and that's how you send referrals across to us. I'm hoping most practices are familiar with that because we have been receiving referrals. And I just wanted to put kind of 3 bullet points there. If you want to pretty much guarantee that the referral is going to be accepted from us, please make sure that those 3 things are obvious in the referral form, because our staff are triaging daily, and those are the 3 things we are looking out for. So just to quickly mention, the COVID infection has to be 12 weeks ago or longer. If it's not 12 weeks yet, then it could technically still be acute COVID, and we would hope the symptoms would improve. The second one, the mandatory investigations have to be complete, as Chetna just went through with us. And then thirdly, this is an area that does lack, so we are quite flexible on this one, but the patient has to have some kind of therapy aspiration or goal. We are very, very rare to reject referrals now. The only time we do is when it's clear that it's a medical action. So we sometimes get referrals asking us to kind of have conversations with patients about whether they should have another vaccine and those types of things. And that's not what we're here for as a service. We're a therapy service. So I just wanted to stress those 3 points. And if I could get the next slide. This is really our final slide, just to look at what we offer as a service. So once the patient has been assessed, we assess patients within 6 weeks of your referral. That's our gold standard, and we're hitting that target relatively comfortably now, which is brilliant. There was a time when we were really struggling to hit that target and patients were waiting a very long time. Now they're waiting somewhere in the region of 4 weeks from the point that you refer to the point that we assess. We then have, depending on how that assessment goes and the kind of clinical outcomes, we have 3 in-house therapy pathways that we could enroll that patient in. The first one is we offer a breathing clinic. So this is run by our respiratory physios, and they're looking for possible breathing pattern disorders and prescribing breathing exercises to try and normalize that patient's breathing pattern if it's been altered from the COVID infection. The second one, and this is our most popular, is our long COVID recovery groups. So these are 6-week groups focused on long COVID recovery and also a big element of peer support, and trying to get patients to understand their, where they're at in their recovery journey, and also learn from other peers who, are going through similar challenges as they are. And then finally, as Chetna said, fatigue is the biggest symptom associated with long COVID. A lot of people don't realize that. They see it as a respiratory condition, which it's not in the main. So we are seeing a lot of our patients have complex fatigue. So we run a one-to-one fatigue pathway run by our occupational therapists. And that's really looking at the 3 Ps there on the slide: planning, pacing, and prioritizing, and trying to kind of incorporate fatigue management strategies. If I just go on to the next slide there, Steph, I've just put the details there for our service. I'm not sure if we've got chance for questions. Happy to take them if we do. If not, then you can pop us an email and that comes straight through to our service.
Okay, thank you, Andrew Chetna. Quite a few questions actually. She told you written down a couple of questions. Do you want to say them out, or shall I read them?
Yeah, you can read them, Nadine.
Okay, so the first one's quite specific about whether you accept patients who are under the oxygen clinic, and also for housebound patients. Is there a service for housebound patients, or are they expected to go to the clinic, or do you have any kind of adaptations you make for people who can't come there?
Sure, yeah. So it's a yes to both questions. So I'll start with the oxygen one. We would accept a patient who is under the oxygen service. We would, though, really want to check, to make sure that this isn't an exacerbation of their pre-existing health condition. So it might be that they've got COPD or something like that, and we, want to check it's not an exacerbation, that this is long COVID. But as long as you do the bits we've discussed in this presentation, if all those kind of boxes are ticked, then we would be happy to see that patient, regardless of whether they're open to the oxygen service. And then the second one about housebound residents, yeah, we would see them. We have options to do remote work, so we can do telephone and video calls if the patient is kind of tech savvy and able to do that. In the very rare cases, we could do a home visit, although we don't kind of advertise it too much as a service because we have a very small capacity and we operate across 2 boroughs, so Newham and Tower Hamlets. But please, if that patient needs our service, get them across to us and we'll work that out as a service.
Okay, is that okay, Sheetal?
Perfect, thanks.
Okay, and we were just asking about looking at outcomes in terms of, I suspect she means improving patient outcomes and well-being, and how long are patients kept under your service?
Yeah, a bit of a golden question about the outcome measures. We have several projects and big pieces of work that are happening. The easiest thing to say is, yes, we do have evidence that the vast majority of our patients are improving. It's really tricky to make that, statistically relevant and quantifiable, which our commissioners want to see, hence projects that are underway. And there is also not one tool that looks at long COVID recovery. So Chetna said there's over 200 recognized symptoms, and we need to use symptom-specific outcome measures. And obviously, I'm not going to be asking my staff to collect 200 outcome measures for every patient they see. So it is a really difficult area, which I'm sure that's why you've posed the question. We are seeing patients improving, and that's the kind of the main thing to say. And sorry, there was a second part of your question which has gone out of my mind.
About how long are patients kept under the service?
Yeah, there's no hard and fast rule. We work with patients on those pathways, and then we aim to get them discharged. And our focus is on kind of self-management and us teaching the tools, the techniques and strategies for patients to then go away and continue that learning. So we're not expecting, you know, patients to fully improve during our time. But we're very flexible as a service. We do have patients who've been with us several months, some even over 6 months, where there's different elements to their recovery that we need to take account of.
Okay, thanks for that, Andrew. And Sophie's just written a question down about being put off slightly by referrals, by kind of letters coming back asking us to do a battery, or general practice to do a battery of tests. A lot of the time they come across as inappropriate, and onward referrals to rheumatology, neurology. So I have seen letters coming back from the long COVID service with similar recommendations as well. Anything you want to say about that, Zoe?
So when we do the initial assessment with patients, we have a questionnaire that we use, which goes through some of the main symptoms of long COVID. And I think when we do the questionnaire, patients do have lots of symptoms that they want to discuss and tell us about, because there are so many symptoms of long COVID. And as you saw from the slides, patients are quite complex. They have quite a lot of symptoms, and the symptoms do seem to cover different systems. And because we're a triage service, and we don't have the input to do investigations and referrals from the actual service itself. We do actually have to pass that back to the GP at the moment. So that it can just be reviewed, and if any further investigations are required, then they can be done, so that we can focus on the therapy side. Sure.
I mean, if you've got a patient who was reasonably well and has COVID and then develops kind of a multi-system or symptoms, and the kind of clinical judgment that this is long COVID and post-COVID, is that not enough in itself, or do they really need to be referred onwards to specialty? Because at the moment we're struggling to get referrals and patients into specialty clinics in the hospital. And if you wait for that, I mean, it will probably be many, many months or even longer before patients are back in primary care.
Sorry, Chetna, I'll come in just before you do, Chetna. I just wanted to say as well, the letters that the service send back to the GPs are a way of us kind of passing that responsibility back to say that the GP can then make their own clinical decision of what is best. Now, we never want to just write a blank letter to kind of say, you know, we've seen the patient, now we're passing all of this back. So we like to give suggestions of what things could be possible. So that's possibly where these letters have been coming back to say, you know, consider neurology, consider X, Y, Z. But at the end of the day, it will be the GP's kind of clinical decision as to whether they feel that is necessary or whether this is purely related to long COVID. And I guess the point to stress there is that we are a therapy service, so we don't have the abilities in-house to consider those onward investigations, hence why we kind of recommend the GP considers them.
Did you also carry on seeing the patient in your long COVID service for the therapies, or at that point is the patient discharged back to the GP?
Usually we would continue. So I imagine the letters have been sent out after the assessment, and it will say, okay, in the assessment, the patient raised X, Y, Z. These are outside of the clinic's responsibility. So can the GP look into them? And we as a service will be doing X, Y, Z, which are our kind of therapeutic pathways.
Okay, that's fine. Dr. Chetna Patel.
Yeah, I would like to add one thing for the investigation. I have usually found that vitamin D deficiency is implicated in many things, and many times is forgotten. You know, the patient has a vitamin D deficiency diagnosed 2 or 3 years ago and is not taking any treatment at the moment, and GP forgets that. So I just point out that. Thank you.
Okay. Sophie, you made another couple of comments. Do you want to say them out?
I can do. I mean, it's just the same thing. We get so many letters, and the patient has obviously seen the letters, and it just always feels. I'm really reluctant to refer to the clinic now, because where I'm having a conversation, kind of trying to channel them towards, you know, managing the symptoms, being aware that this is a long-term thing, that you know, it can be helped with therapy, but possibly a lot of these things won't go away for a while, and we don't know when they'll go away. And then actually what comes back is something that says, you know, refer this young patient to ophthalmology, neurology, rheumatology. I know you're saying it's the GP decision, but that once, I don't understand why you ask so many questions about things that you then can't do something about. You know, maybe focus on the bits you can, because it just leaves the patient feeling that there's this whole basket of things that someone is going to fix. And I mean, so far, a lot of the things in COVID aren't fixable, are they?
Okay, thanks, Sophie. And Dr. Werner?
Yeah, just a quick comment on this. So I was involved in generating the template for East London. It was generated with national colleagues, and it's a national requirement. So I think none of us wanted to do this, but it was NHS England who wanted us to include all of these things.
Thanks for that. Andrew?
Yeah, I'm really pleased you made that comment, and Sophie, I totally get your point. And there was a comment in the chat earlier on that was saying that long COVID is becoming very medicalized, when actually it needs to be more therapy based. I think, yeah, the challenges we do know about, and we are restricted by NHS England in our commissioning structure. And we also, because there are elements of long COVID that is very medical, we have to have medics within our team, but then that does then get complex, because once we identify something, we can't always kind of provide a solution to it. So I take your points on board, and I'm happy to discuss them further with the team. And sorry, I know Chetna wants to come in there too.
Hi, Sophie. Yeah, so just to add in there, so I think the patients don't get the same letter that goes out to the GP. The one that's made for the GPs is one that we make following discussion in our MDT. So the patients get a simplified version of that, which doesn't have the requests on there, but just more of a summary. A lot of our patients have got brain fog, so we find that just telling them the symptoms and what the plan's going to be is quite difficult for them to keep in and to remember. So the patient letter provides a list of the symptoms and also lots of different types of referral pathways for them, so that, you know, they can self-refer to IAPT as an example, or to Yoga for Life, so depending on their particular symptoms. So it's more for information, the one that goes out to the patients.
Okay, thank you for that. Is that okay, Andrew? So you've had some feedback really about the service and some of the kind of frustrations from both clinicians and patient experience, and I know you're constrained by some of the national kind of it appears the national kind of direction or NICE guidelines, as Dr. Werber said, but hopefully we'll see some kind of expansion and improvement in the service going forward for patients.
Yeah, I'm happy to. Yeah, whether expansion's the right word to call it, I'm not sure, but I'm happy to take those comments further with my team. And if we are ever able to come back, you know, because I think it's important to have a kind of dialogue with our GPs, because it's yourselves that are the referrers and the kind of gatekeepers in for these patients. So it's I'm
just feels like there's a need which isn't being met for long COVID sufferers, I suppose. And so yeah, it would be great to have you back and to give us an update and hopefully changes going forward. Thank you both of you.
Thank you.
Thanks, everyone.
Should we move on to Sule? Hi, Sule.
Hi, Nadine. Thank
Is it just you or Dr. Munir as well?
I don't think Munir is on the line, and he could only do up until 1:05, so I am assuming that he's not going to be here, but I am here.
Okay, well, I'll hand over to you just to give us a fellows update.
A quick update from me, Nadeem. Steph, can we have the next one, please? Next slide. So I'm going to provide you some brief information on the Salaried Portfolio Innovation Scheme and Newly Qualified Fellowship Programme. As you know, the Newly Qualified Fellowship Programme is a national programme, and we have the Salaried Portfolio Spin element also in London. Overall aim for the programme is to support recruitment and retention of our newly qualified professionals, GPs and GPNs. It's a 2-year programme, open to all newly qualified, so there isn't a selection process as such. Whoever wants to actually join the programme, they can join the programme and we would support them. Nursing element, and this is really important as well, has been changed recently with a lot of campaigning from all the localities. And now it doesn't only include the newly qualified, but also the support is extended to our nursing colleagues who are transitioning into primary care. So it includes those newly qualified, but those who are joining primary care at any point in their careers. The program offers opportunities for portfolio working, learning and development, post-registration, peer support group, which is provided by our program director, Munir, and mentoring to increase retention and to maintain high level of participation in this program. Portfolio elements and portfolio partners can be any organizations in the system, including our PCNs, practices, local authorities, federations, trusts, training hubs. And we have great example of these opportunities in Newham, which I will come on to. The national funding supports 1 session a week for our fellows. The portfolio, if the portfolios are for 2 sessions a week, the expectation is second session is paid by the portfolio provider. Each fellow select their own route for the program, and they can also develop their own portfolios to support their development depending on the interests that they may have. Next slide, please, Steph. So national offer, which is 1 session per week, is paid to practices with own cost. And the benefits to practice include a GP, GPN in a substantive post, financial support to fellow, to develop access peer support group, as well as mentorship, impacting positively, hopefully, on their retention. There is also a GP cert offer from HEE. Payment for this element goes directly to our fellows according to our HEE guidance. And at the moment, there isn't anybody in this program from Newham actually taking up on this offer. Next slide, please, Steph. We had 15 fellows in Newham up until January. 7 of them completed their fellowships between October and January this year. We have 8 active fellows at the moment and 10 potential fellows that we are working to onboard them onto the program. 6 of them are GPs and 4 of them are GPNs. There are some testimonials here from our fellows who were in the program, and they actually talk about how the program supports their development and how they are kind of continuing their professional development by getting into some leadership roles. Next slide, please. In this slide, you can see some of the portfolio offers taken up by the fellows to date. There's wide range of offers that has been provided and the fellows are supported with. Next slide. That also shows the new portfolio offers that we are developing. So there is one element that Training Hub PCM working. I think if Munir was here, would have said that we would really love to have conversations with our PCN clinical directors in terms of how this can be developed. We have recently developed immunization fellow and urgent care fellows. Both offers are out, so we are expecting expression of interest from our current fellows, and we will continue to promote it to the new ones that are onboarding into the program. We are also looking at developing children and young people fellow with parts and climate and air quality fellows with our colleagues in Luckmore of Newham. You can see some information here about the peer support sessions that are supported by Munir. Also, GPM fellows have got peer support sessions that are also supported by our program director for GPN, Charlotte Cooley. Next slide, please. You can see our website here and the registration link for all the fellows. So if you do have colleagues who are newly qualified, not yet actually expressed their interest into the fellowship program, either GPs or GPNs, please do encourage them to register their interest so we can work with them to onboard them onto the program. Next slide, please. And we also developed a Newham web page for our fellows. You can see all the different portfolios, all the information about our fellows, and some videos and clips to encourage others to actually join the program. Next slide, please. And also some useful links in terms of some of the guidance around fellowships, and spin offer, for example, what that might mean, etc. But if there are any questions, I can either take them or you can always email me so that I can answer your questions.
Okay. Thank you, Sule. Karen, can't see any hands raised. Any questions?
Suggestion from Rima that Sule might like to just share with colleagues the information about the recruitment process that's underway, which does seem, I think, probably helpful. We've shared it, but colleagues may not have seen it.
Yes, of course. We are currently recruiting for our training hub clinical lead for Newham. The application process is open at the moment, and we are expecting applications up until next week on the 15th. We are going to do the interviews week after that. There will be a shortlisting process from the applications on the 16th, 17th, and we are going to inform all the successful candidates and invite them to an interview for the week after. Please do have a look at the information that is being circulated by our federation colleagues. We have circulated to our networks. Other colleagues have also circulated it, but if you haven't received it or haven't seen it, please do get in touch with me so I can send you the application form, job description, etc., and hopefully be able to support you in your application and encourage you to apply.
Thank you, Sule. Yeah, and if you can pass it on to us and we can send it out with the webinar as well.
Lovely, I will do that after this meeting.
Thank you.
Thanks,
there's no questions, but thank you really for the update on the fellowships. Really important work you're doing to help with our kind of retention and recruitment locally of clinical colleagues.
Thank you, Nadeem, and we would really welcome the opportunity to talk to you again in terms of developing portfolios with our PCNs and practices. If you want me to do that, please do let me know.
Yeah, sounds really good. Developing other areas on top of what you've shown already, that'd be great.
Lovely, thank you.
And Nadeem, if I can just chip in, as Claire Davison has put, NHC is supporting the opportunity around urgent care fellowship, and we would certainly welcome anyone who wants to have a conversation, Davison or us, about that opportunity, alongside obviously the training hub college as well.
No, thanks for that.
Thanks, Karen.
Thank you, Karen. So just contact Karen or Claire or someone at the Federation. Thank you, Sule.
Thank you.
Should we move on to dental services update? It's hi, Luckmore.
Hello, everyone. My name is Luckmore Zinyengere. You can call me Lucky. I'm an extended duty dental nurse employed by Kent. And we do have 2 teams. If we can go to the next slide, please. Okay. Our main aim here is to improve oral health in the community. And looking at the numbers that we've been given, Newham has got really, really bad, very bad numbers on dental decay. So it's 39.4, which is well above the average of England. So we really have to do something. We are trying to reach to every corner where everyone can help us to improve oral health in this community. Next slide, please. So we are Kent Community Dental Outreach. We've got 2 teams, INEL standing for Inner London, and they're based at Stratford. And with another team is the ONEL, which is Outer London, based at Hainault Health Centre. We do oral health education to the community. We go to events. You can even invite us to come when you do your immunization, because we are doing the same thing with Hackney. They do immunization even during the weekend. 1 or 2 of our team members can come and join you and just lay out all this information to the community. We also do care home support, where we go into care homes and we train staff members on how to look after the residents' oral health and improve the oral health of their residents. We also do community dental service referral. We are a referral service only. And we do have clinics in each and every borough that we are in. In INEL, we cover Newham, Hackney, and Tower Hamlets. So we do have clinics in all these boroughs. Our ONEL, which is Outer London, is Barking and Dagenham. We do have a clinic. Waltham Forest, we do have a clinic. What's the other one? Havering, we do have a clinic. And Redbridge, we do have a clinic. So we do have clinics in each and every borough where they can patients can be referred to us from the general dental services. They can refer the work that they cannot do. We can do the work and then send them back for their own use. And we also do fluoride varnish programs in schools and nurseries, where we go into schools and we paint fluoride on children's teeth twice a year, and we also do supervised brushing, especially in special needs schools, where children do learn how to brush their teeth at school. They do brush their teeth at school every day. Next slide, please. When we give out this information, we have got 3 key messages, which is toothbrushing, that is meant to be done twice a day with a fluoride toothpaste. We do encourage them to do what we call a dry brush, where they don't use any water at all. They just brush and spit out with no rinsing and no eating or no drinks after the brushing for at least half an hour. We also encourage on the diet, where they can all limit all the sugars to meal times only, so that they can give their teeth time to recover from the acid attack. And we also push on the regular dental visits, where we say, please, parents, do not just visit the dentist when your child or when you are in pain. Especially with the children, it's really difficult for them when they have to come to the dentist when they are in pain. They won't cope. So these 3 key messages, those are the ones that we encourage on when we move on. Can we move, please? And we are well aware that NHS dentists are really hard to come by these days. So we do give them information on what to do and where to find an NHS dentist. Next slide, please. We also want them to know that there is a link between oral health and general health. And all these, if we can just click on every, yes. All these conditions, they are all linked to oral health. If your mouth is not healthy, they can be affected. So we really want people to know that they have to look after their teeth. They have to look after their mouth, especially the gums. When you've got diabetes or any other condition, that can get worse because of the condition of your mouth. Next slide, please. And how do we access the dental dental services? Okay. Not everyone is exempt from paying. You've got to be on these exemptions, whether it's a job seekers allowance or your pension credit. I know some of them have changed names, but if you are getting any support or any benefit that will exempt you, please, they must present the exemption to whoever they are, with the dentist or anyway, so that they can be exempt. If they are in any agent out of hours, they have to call 1111, or NHS Community Dental Services is clinic appointment only by referral, and NHS Community Dental Services is also a domiciliary visits by the dentist and the nurse. So we are able to do this on housebound patients, yes, but we are limited to the range of treatment options that we are able to do. We are unable to do any radiographs at home. So what the dentist can do is very, very limited when they do domiciliary. So if you have any queries about the referrals, or you would like to check on the progress of the referral, you can contact the referral team at that email address, by referral on that email address. Next slide, please. So this is our criteria, the referral to the community dental service. We've got a level 2 and level 3. That's what we accept. Referral accept to those that cannot be treated at the general dental services. That is level 2 and level 3. What do we mean by level 2? It can be special needs who have medical or physical, mental conditions, which makes access to the NHS dental care within general dental services difficult. That's level 2. Or that level 2, or those patients that can go and see their general dental practice for a general examination, but when it comes to treatment, they can't be treated. They will need either a inhalation sedation, IV sedation, or they need general anesthetic. That's when they can be referred to the community dental services. People with phobias, yes, they can be treated. That's treatment only, not examination. They can be seen by their general dental service, and then when it comes to treatment, then they can be referred to as, they do the work and they refer them back to their own dentals. So those are the links on how to refer patients. You can have a look at them, and that's a QR code on dental referrals as well. Next slide, please. Regular dental visits are free for children until the age of 18. And it's also free for pregnant women and nursing mothers until the baby gets to 1. So if for any exemption, they have to fill in a form, HC1 form. They can be partially exempt or fully exempt. They can get a full exemption, which expires after every 12 months. So dental checks, we also push on dental checks by 1. Children should be registered by the dentist as soon as they get to 1. Next slide, please. That's our dental health information. If anything, any resources, are there any questions? And thank you for listening.
Thank you. Can patients self-refer for this outreach team?
Self-referral, that is if they can meet. I don't think self-referral is the GPs, I know they can refer patients. The school nurses can do that. The early years, yes.
What about the care homes? Can the care homes and
yes,
the
care homes,
teams?
yes, the care homes can also refer. They can also refer their residents to the, if they meet the criteria, if they want any domiciliary, yes, if they think they fall under the criteria that I've just mentioned, yes, they can be referred. And the only thing that I can advise you to do is, if anyone is referring anyone, please make sure you put as much information as possible so that that referral is not rejected. Because by being rejected, you're wasting a lot of time. That patient will take time to be seen by the dentist.
Okay, thanks. Anything in the chat bar, Karen?
Just concerns that I'm sure Luckmore's familiar with, that people are finding it very difficult to access appointments. So quite a few colleagues reflecting that patients and their personal experiences, they're just not getting appointments. Yeah.
Yes, we are quite aware of that, because dentists are really hard to come by these days. We are well aware of that. This is why we're sharing how they can get to a dentist, how they can find a dentist. And with the dentist, it's not like the GPs where you are confined to your area only. You can go anywhere in England where to go and get a dentist. So you can go find a dentist. If they can go find a dentist, excuse me, if they cannot find a dentist when they go, there is a number. They can call the NHS England Contact Service Centre, and we always share this number with them. Unfortunately, I didn't put it there, did I? No, it's not there. It's on 0300 311 2233.
Okay, thank you for that. Yeah, so it's just really about access to dentists, which is the feedback.
Yes.
But I understand that's not, fully under your remit. Is that okay, Karen? Can we get that number also out to practices as well?
I've just put it in the chat bar, so thank you. I quickly typed it in as you were speaking, and we'll make sure that goes in the resources. And I know, although I think the challenges are going to be there for a little while, we happened to be part of a conversation with commissioners yesterday that I believe the dental contract is now going to have some shift, so that the ICB has got some opportunity to oversee and be more involved in the delivery of the dental contract. And it so happens that for North East London, that is going to be led by William Cunningham Davis, who's also the primary care lead for our patch. So whilst I don't doubt it's going to take some time still to get these challenges moving forward, I think perhaps GP colleagues will have the opportunity to liaise perhaps just a little bit more keenly with William leading that work as well. Okay,
thank you for that. Thanks for the update. We'll pass the information to the practices. Should we move on to our older adults mental health update? Hi, Sylvester.
Hi, good afternoon, everyone, and thank you very much for giving us the opportunity to meet you today and actually to find ways of working together collaboratively for the older people in Newham. Of course, my name is there. I'm Sylvester Lamin. I'm the operational team lead or the manager of community mental health team for older adults in Newham. I think I have my colleagues who appear online as well. Our newly employed liaison practitioner who is going to be working with the GP surgeries across the borough. And also likely Dr. Brown, one of our consultants, is also on the line. Okay, next slide, please. Just give you a brief structure, information about the team. We have two teams. We have the community mental health team for older adults. That is the team that deals with all functional and people who are diagnosed or organic service users. Then we have the diagnostic memory clinic. They are just there to diagnose memory clinic, assess and diagnose. They don't follow up. They don't do anything. They are not dementia service at all. Anything dealing with dementia is being absorbed by community mental health team. That is the CMHT. Next slide, please. So this is the composition of the team. We have the medical team, we have a consultant psychiatrist, then with a couple of junior doctors. We have psychologists, we have occupational therapists, we have nurses or CPNs. We now have our new liaison practitioner, the one I mentioned about. We have community support workers and the admin staff. We don't have any social workers in the team. Next slide, please. Sources of referrals, of course, the bulk of our referrals actually come from the GPs, and this is why it's really good for us to actually work together more collaboratively and see how we can develop communication and other issues among the services. The others, of course, we receive referrals from social care, inpatient services, whether general hospital or psychiatric hospitals or other mental health services, care homes, carers and service users. They do refer themselves to us. Sometimes they come directly to our door. We don't turn them away. We have voluntary organizations that can also make referral to us. We have community link workers, community connectors, the police, etc. Next slide, please. So how we manage the referrals, this is very important. Well, of course, we have only one single point of entry. So all the referrals that come to us, they go through our single point of entry. Maybe I will send the email address. I'll put it in the chat. So what we do every day, there is a allocated duty worker. When the referrals come through, the admins will pick the referrals up, pass it on to the duty. The duty, we just check it through quickly to see, is it for memory clinic or is it for CMHT? Then also, is it something that is urgent or non-urgent? So they then they triage it. If it's for CMHT, then it goes to the CMHT document. If it's for memory clinic, we also pick it up. So what happens from there? So if it goes to memory clinic will also have their duty worker who will be screening the referral to see is it appropriate for the service or is not appropriate. If it's going to be declined, definitely they will inform the GP that we have declined this referral because of ABC reasons. CMHT, we hardly actually turn down anyone because, as you are all aware, older adults when referred, they have complex problems. So even if they don't meet our criteria, then we can assign them to other services within the borough who we feel appropriate for those services. The memory clinic, I start with that. So as I was saying, once the referral is accepted or screened and accepted, then they will be put on waiting list. I think this is where really is very important also for you to have the information. According to our guidelines, the people will be seen within 6 weeks of referral and diagnosed within 18 weeks of referral. However, as we are all aware, during the COVID period, we have a backlog of really waiters, which we are trying to reduce. We are almost getting to that point. But when making referrals, this is what really we want people to be aware of, that we are not going to, if you refer for memory assessment, they are not going to be seen straight away, but they have to be put on a waiting list. So we try as much as possible to contact them. And part of the referral screening, really, we contact the service users or their family directly and talk to them. We also give them that information. For CMHT, we have it's the same process, but we have about up to 28 days to see them. But of course, these days we are doing far much better than whatever is there, what the trust is actually asking us to do. So we've been so much proactive, and also depending on the RAG ruling, whether it's urgent, we can, if it's urgent, we can allocate somebody either on the day or maybe the following day to go and assess them and do what sort of intervention we want to do. So that is how we manage the referrals. Go ahead, please. Yes, so the current challenges and areas we think that we can work together. One of the issues that we're having, we don't have access to your system, EMIS. I think this is the area where we will want at least 1 or 2 staff from our team to actually have the access, so that if we need information, we don't have to be going back and forth to you, the GPs, for us to get that information, if at all we have, and we have access to the records and also be able to read whatever information that we have. Then the other issue there is the inappropriate referrals. What we calling their inappropriate referral. It has more specifically for memory clinic, for example. Somebody who is recovering from UTI, or let me say delirium, or let me say for any infection, for example, or somebody who is actively drinking alcohol. If you refer those people, we will consider them to be inappropriate referrals. If somebody has got UTI, you have to allow at least time for that UTI to recover. And even if they are having memory problems, at least you have to give us a time frame. How long has this cognitive problem been going on? It could be an acute problem that is causing the confusion or the cognitive or memory problem. So once we get those referrals, we don't actually take time after screening them, asking the family members or service users if they confirm that this is what is going on, then we can get back to you to say that this referral we consider it to be inappropriate. Inadequate referral information. I think my colleague who was just saying there, if you don't give us much information about the service user, then it will be difficult for us to actually screen and process the referral. Sometimes we receive the referrals only one single line, or this person has got cognitive problem. We don't know the details of it. How long has this been going on? What are the issues there? What investigations have been done so far? These are some of the information that we really want, that will help us to process the referral as quickly as possible and be able to identify whether this is urgent, not urgent, or this is something that we can address as soon as possible. Then low diagnostic rates in Newham. This issue has been going on. I think the expectation of the commissioners is that we have to actually assess and diagnose about 66.7% of the prevalence in Newham, but we have never been able to achieve that. And now we are trying to work together. Since most of the referrals we get, they are coming from the GPs, we are still trying to find out how the data is being collected. The issue is we have been asking ourselves, and maybe you can enlighten us more, how the figure is being collated, whether is the number of referrals you make to us and the percentage of that referral that we assess and diagnose, or whether they are taking Newham in general, how many people are actually diagnosed, because we don't have records across the borough, wherein because people are being assessed and diagnosed at Newham, maybe Dr. Warren and her team. Sometimes we don't get that information. It's only coming from you. And sometimes people from inpatient services or people who are being diagnosed by some of the GPs, they will say, okay, this person has dementia, for example, but we don't have any record of that. Or is it that we are not providing enough information for you to be able to update your records? So that is what really we want to work together. We are trying to put plans in place to make sure that we increase the diagnostic rate in Newham to meet the national standard. Then physical health monitoring. Sometimes some this is one of the areas where we have having problem, particularly older adult services. We have found out of late after COVID, or even during COVID, most older adults were not able to access GP surgeries. Some of them coming to us, well, a few of them, they have been actually discharged or deregistered with some GP surgeries, and we end up picking those points. So these are areas we need to consider. If you have anybody on your under your care that has got mental health problems, instead of just discharging them, if you let us know, we'll be able to follow them and make sure that yes, these issues are being picked up. And not only physical health, of course, their mental health as well. Sometimes people will relapse and they will not be able to even call GP or call any services whatsoever. And some of them, the older adults, we have found out of late, they don't even have mobile phones, for example. They don't have anything at home whatsoever. And when we pick the cases up from other referral sources like the police, social services, you will find out that this person has been living in a flat that is being neglected, no heating, no electricity, no whatsoever, no contact details with. So these are some of the things that we feel that we can consider and make sure that we try to minimize that gap. Then the other one, which has also got a link, people we discharge from our service to under your care. As I was saying, people who are being diagnosed with dementia, for example, because we don't have the dementia service as per se, most of the people diagnosed with dementia, they are discharged back to the GPs, And those people, we feel that they are no longer benefiting that much from CMHT, for example, we can discharge by impact. But because mental health is a complex issue, of course, older adult issues, some of them, they will fail to engage and they slip through the net. If you have them, let me see on your caseload and see that, oh, this person has, we have trying to get hold of this particular service user, but we are not being able to do so. If you get back to us, then we'll be able to follow up. So these are some of the areas really we want us to work together so that we can bridge those gaps. Then people with suspected mental health or cognitive problems, but they don't have access to other services at all. As I was saying, we are coming across a lot of these people these days, and we're having a large number of referrals, not only coming from the GPs. And when we pick them up, we find out that there are so many safeguarding issues really involved. So that one also gives us some time to start following up, making other referrals to make sure that these people are actually safe and receiving the care they need. Next slide, please. Yes, so these are the positives that really acknowledgement, which we are sharing, not only coming from our teams. Of course, we have HIE, that is the Health Information Exchange, wherein we are able to access some information from the GPs or primary care in general, and also general hospital. We share that note, but it's not, of course, a comprehensive one because we don't have access to emails. Our responses to referrals has been generally much quicker than we are expecting. So because of the transformation as well, as we are going along, we are trying to organize ourselves and make sure that we are so responsive, so that instead of referring somebody, for example, waiting for 28 days to be seen, depending on the information on the referral, we can see that person either on the day or the following day. So that is how now we are practicing. Then, of course, if at all we decline people, for example, we have now been proactive in sending the letters to the GPs to explain that this is the reason why we are declining this referral. If you provide us that information, then we'll be able to proceed with the referral. So that one has been working well, and also there have been some email exchanges with either our doctors or our assessors or our CPNs. That one has been working for now. Then links to community health, Admiral Northeast, Newham General Hospital. There has been some links really when we have been working together of late, collaboratively. Although we don't have social workers in our team, then of course, when you make referral, there's still some nags. We don't know what is happening on your side, for example. We don't know what is happening on the side of social services. So at times there are delays, at times we get quick response from them. So there have been that collaborative working. Then, of course, we are happy to support the care homes, as I said, and we are happy to join any meeting that you can organize that you feel, whether it's community connectors. Now we have liaison. Jackie is on the line there. We have a liaison person. So if it's in the PCNs, you can actually bring a case up and maybe send us or Jackie an invite. Jackie will be able to attend that meeting. And any cases being picked up, Jackie, instead of now coming with making a new referral, Jackie will bring that case to us. We can pick it there and then. There is always a duty worker and also psychiatrists on site. So if you want, you can send an email or make a phone call that this is the case. Can you please join this or follow up this particular individual in the community? And also we are available for advice. If sometimes the referrals that we get, we only need the GPs, you only need an advice, maybe on medication or so. If you send an email, we pass it on to the doctors, you'll be able to get that advice as soon as possible, rather than making a formal referral, and then things will delay. Then improvement planning to care homes liaison. We are planning ourselves to make sure that how we can work with the care homes, particularly in the area of supporting them with people diagnosed with dementia, challenging behavior, people deteriorating. We have had a few kind of safeguarding issues from the care homes, and the commissioners are now asking us to actually provide more input. We have been providing input, but of course, because of COVID, there have been a lapses in the way we are working. So now we are trying to revamp the way we work with the care homes.
Sylvester, can we just in interest of time, can we just move on to maybe the next slide and maybe take some questions?
I think this
please?
is the last one I can say.
So should we move on to some questions maybe, because there's some comments about referrals being rejected for dementia patients. I know in our own experience, quite a few have been rejected for delirium or depression in the past.
Yes.
And I suppose you've got that kind of issue of not having having patients who have not been diagnosed with dementia locally or coded appropriately. So anything to add about dementia referrals being rejected?
Well, I have been touching on that area. Sometimes if dementia people refer for cognitive assessment, for example, why on most cases they are being rejected. Let me say somebody recovering from delirium, for example, or somebody has just been discharged from general hospital where they have been treated for UTI. You need to wait for some time really for the patient to recover fully, and then we can pick up the assessment. But if somebody just coming from general hospital being treated for delirium, for example, they have not fully recovered, then you refer that person for assessment. You will not be able to get accurate assessment of that person's presentation.
Okay, thanks.
And those are the areas, yes.
That's fine. Any other questions in the chat bar? So, what about patients being rejected for having a history of depression?
Well, anybody,
even if their symptoms have, even if they're not currently depressed.
Well, anybody being referred now, we are also looking into that. When they have depression and other underlying mental health problems, we don't reject them because of that. We can only say we are not going to set them the memory. We can take them on for the depression, for example.
So will you, could you also run the CMHT for older people and also the memory diagnostic clinic? Would you move someone into the CMHT for older people if their depression is bad enough that it is coming across as dementia type symptoms?
Yes, that is now what we do. In fact, what we do, if you refer somebody for memory assessment, for example, but we find out that they have got challenging behavior, depression, or any other underlying mental health problems, we transfer them to CMHT. We do whatever intervention we need to do then before we can transfer them back for memory clinic. So these are some of the things that we delay, for example, in terms of assessment.
Okay, that's fine. Yeah. Okay. Anything else in the chat bar? Any questions?
There was a question about community languages and whether the service is able to provide support for people that aren't speaking English or don't have English as a first language.
Oh yes, we do. We do book interpreters. At the same time, we have some bilingual support workers or staff in the team, doctors, nurses, OTs, and so we know that yes, the borough itself is diverse. So we have a diverse kind of staff.
Okay, thank you. Anything else in the chat bar, Karen?
Well, just Ashito, I think you were asking some questions just around the liaison points and things. So I don't know if you wanted to add anything further. We've picked up a few of them.
Well, Jackie is there really. Jackie, you are online. You are mute at the moment. Can you please say something?
I'm muted, yeah.
Yeah.
Just because I've put it in the chat. So yeah, I am the only liaison nurse practitioner at the moment. Hopefully, there will be more of me. It's hopefully in the future. I hope, fingers crossed. But it's only me at the moment. I have sent emails around to all the surgeries, and at some point, I will be visiting as many surgeries as I can. But as I said, I am on email, so I'll put my email address. I don't have a mobile, but the office line is on the end of my signature. Please just send me any queries, questions, anything you want to discuss. I think my first surgery that I'll be going to is Greengate, who have kindly invited me to come over. So I will be making my way around.
Okay, thanks, Jacqueline. Look forward to seeing you, and any kind of questions and issues with referrals being rejected, I assume we can pass on to you. Is that correct?
Yeah, yeah.
All right, that'd be great. Thank you very much. Thank you, Sylvester and Jacqueline. Anything else to add, Karen?
No, I think that the questions that were asked were covered. Thank you.
All right, look forward to seeing you, Jackie. Thank you very much, everyone, and we'll see you next month. Bye.
I'll put my email in the chat. Someone's just asked.
Yeah, and just in case, colleagues, all of the slides and contact details and so on will be shared out in the regular newsletter that will come out after.
Thank you, everyone. Bye.
Thank you, everyone. Bye. Have a good day.
Thank you. Bye.
Bye.
Bye.